So it's my pleasure to introduce Gail Cohn, who I met about, I guess it must be 10 years ago.
It has been.
Yep. And a dear colleague of mine. Let me tell you a little bit about Gail. Since 2013, she's been the DC Age-Friendly Coordinator, mobilizing public and private resources to transform the city into a better place for not just older residents, but all residents to live, work, and play in accordance with the WHO guidelines. DC actually received international recognition for its accomplishments in the 5-year age-friendly journey. On behalf of the mayor, Gail is leading the second 5-year round age-friendly DC initiative following the release of the 2018-2023 strategic plan. A 2-year progress report was released in January 2021, which we kind of use in one of our classes that Gail teaches in. And later in 2021, Gail was recognized along with others by the K. Fritz Foundation for her outstanding performance and exemplary service to the DC government. I want to emphasize that Gail is a GW alum in the health administration, health policy program. She has taken on numerous national, regional leadership roles. She's a founding executive director of Collington, a continuing care retirement community. And she's also the founding executive director of Capitol Hill Village, the second neighbor-to-neighbor support to stay put organization in the nation. And now there are over 75 villages in the DC metropolitan area. Gail, I guess you don't call it aging in place anymore.
So I've decided that the term aging in place is better living in place than it is aging in place. Somehow, you know, my language changes on a daily basis. I've decided that caregiver is an insulting word. We need to be calling that care partner. So I keep changing my language when I realize that what I'm saying is ageist.
Well, that's a good thing. That's a good thing. So, Gail, would you like the rest of us to introduce ourselves to you?
I'd love that.
You know me, and you know Melinda. How about Keith? Go.
Hi, Gail. I'm Keith Cole. I'm an assistant professor in the physical therapy program. I actually just met you last week through the National Center. Yeah, so it's great to have repeat introductions. So it's great to see you again.
Yeah, we had such a good time. Keith is going to be a partner in stuff that we'll talk about a little later.
I'm excited.
Michael? Okay.
Do you mean me?
Yeah. Michael.
Oh, okay.
Yeah.
Hi. Yeah, my name is Michael. I just finished my first year in the MPH epidemiology track.
Wonderful.
And yeah, I've been attending these Institute for Brain Health and Dementia seminars for a couple of weeks now. I just find aging populations very fascinating and how their responses to COVID have been impacted by it.
Welcome. Okay, Erin Bennett.
Hi, I'm Erin. Sorry, my camera's off. I'm in the office, so sometimes there's like people coming into my camera view. Anyways, hi, I'm a research associate at GW in the Epi department, and I work on Melinda's team.
Great.
Amrapali.
Hi, my name is Amrapali. I am a first year MPH student. I'm really excited for the seminar today.
This is great. We have students here and research assistants. Samira is coming on. Connor, while she's coming in, do you want to introduce yourself?
Yeah, hi Gail, I'm Connor. I've been the one that's been coordinating this with you through the Brain Health Institute. And I guess I'm a first year or just finished my first year at doing an MPH program in epidemiology.
Nice. Samira, we're introducing ourselves to Gail Cohn.
Oh, sure. Sorry, I was in another meeting. I'm Samira Talegaonkar. I'm an associate professor in the Department of Exercise Nutrition Sciences. And I guess my interest is more with related to dietary patterns, diet, and physical function outcomes in aging.
Yeah, so we all have a common interest. And as those of you who have attended regularly the seminar series, this is the last seminar of this series. We started off with some epidemiology, painting the big picture. We got down into mechanisms, that drive brain health. And the last two lectures have dealt with community outreach and what our community partners are doing, with regard to brain health. So I couldn't think of anyone better than Gail to, be the cleanup batter, so to speak. And so Gail, just take it away. Do your thing.
So I really would love it if you would just feel free to stop me whenever you have the urge to speak. Forget the chat function. We're small enough that we don't need to deal with chat. And I really would appreciate being interrupted. Melinda Power, I just want to highlight, made a wonderful report to the Department of Aging and Community Living, which, Melinda, I have no idea whether you follow what happens after you do reports to see how things are changing. But I would say that a lot of things that you were recommending have happened in that agency that have made it a lot easier for people to experience positivity about their brain health. So
yes, it's interesting to see. I don't think I'm aware of everything, but I've heard little bits and pieces come through.
I think it's hard to be a consultant. I've done that role because you walk away from your work and people shape whatever it is that they gleaned from the report into something, but it's not necessarily what you were thinking they were going to be able to accomplish. So I really do. I'll point to stuff as I'm going through what I'm doing. As Melinda and Loretta know, I am not a part of the Department of Aging and Community Living for a good reason. The Department of Aging and Community Living has a mandate through the city and the agency that pays the bills for the work of the Department of Aging and Community Living for the most part, which is to focus on making life better for people who are 60 and over and those with disabilities. That's a different mandate than the age-friendly aim, which is to make life better for people as they grow older. That's what Loretta told you when she introduced me, but I just want to underscore the fact that that's different. Can you sense the difference? Does that mean, do you see what I'm saying? That means each one of you are growing older. You may not think of yourself as older, but you're older than you were last year. And you've had experiences that have changed your life in a meaningful way. And had you not had those experiences, you would be a different person when you become older. If I took you back to your childhood and deprived you from some of the things that happened in your childhood, there would be a different person sitting here with us today. I don't know what you can remember from those years. I remember a lot. And I know very well that if I hadn't been bullied, if I hadn't had the experience of having the last name in my childhood of Lebensburger, which sounded like hamburger, so I was called Burger. You're a hamburger a lot, and I thought it was very useful to get pushed around a bit in those earlier years. I don't know what kind of a person I would have been if I hadn't had as much opportunity to hear what other people saw when they looked at me. I do know that it's pretty darn important that some people get changed in some negative ways because of what is reflected from the community. And we're going to be talking today about brain health. And I want to start by just going around among all of you and see if you will, for me, define what you think brain health means. So why don't we start with Connor?
Ooh, I'd say maintaining a good memory and having a good, just, I'd say like a good day-to-day.
Okay, let's leave that for a moment and go on to Samira.
So I think brain health is also memory, cognition, and also being contributing to society in some way.
Okay, so you've added a contributing to society that Connor hadn't put in his definition. Melinda?
I think I define it as having cognitive function that is the best it can be for where you are in your life.
Wow, you broadened it out so that we have a lifelong experience here in which we're talking about brain health. And you've added, from my perspective, of the change that I was suggesting can happen with experience. So can we go on to Keith?
Sure. So to continue to process and learn throughout life.
I like the learning phrase. That is certainly important, I think, to as a way of maintaining brain health, as well as of being able to enjoy life and be engaged. Erin, where would you take this?
I think one of the things that I would add to kind of the working definition we have right now is, to the extent possible, maintaining one sense of self and identity.
Okay, so I think that's again building on this reflection from other people and how we see ourselves, but I mean we're also reflecting onto others what we perceive. Edward,
Sorry, I needed to unmute. Can you hear me okay?
We can.
Yeah. I think that it's important to recognize each individual for who they are, and that their history really affects what we end up seeing, when we encounter those patients. So we have to remember that you're part of a whole, if you will.
So you're part of a whole. I think we're making this very broad, and I'm very appreciative of the fact that we're not thinking narrowly about where we're talking about brain health. Amrapali?
Hi. I would say I agree with Aaron a lot, but in addition to that, I would say it would be a perseverance of mental and cognitive function, and in the absence, we would like to be healthy as possible in the absence of brain diseases.
Okay, and now you've drawn us into a more clinical direction of how we're thinking about brain health, and I think that's also an important way to view this. Katie?
Yeah, I think I would say a combination of cognitive, mental, and emotional well-being that allows for a good quality of life. And I think maybe a level of resilience and adaptability. And I think it can probably vary by person.
Yeah, I'm gonna go to Loretta and then we'll start going through this and put it with the filter of age friendly. Loretta?
Katie stole my words. But I think more physiologically, and of course, what everyone else has said, and what I would add is these two words of plasticity and resilience. You know, your ability to respond to a challenge, whether it's, you know, a crossword puzzle or figuring directions. And also resiliency, you know, when you suffered some type of mental or emotional trauma, your ability to, you know, come back to function in a timely manner. So that's how I think. I think of the brain as an organ, the same as I think of the heart, subject to the same requirements.
And there's plenty of studies that would support what you just said, Loretta, with regard to that concept. So I think at this point, I'm going to ask if I can share my screen. Age friendly, the activity that I'm involved in is run out of the government and was set up in accordance with a World Health Organization initiative that was started because of Alexander Kalachi. Alexander Kalachi lives in Brazil. His home actually is in Ipanema. And Ipanema, always, I can't say the words Ipanema without seeing the girl from Ipanema. And hearing the song in my head, it just comes up like an earworm immediately. But Alexander Pele, or I'm sorry, Pele, the soccer player, is also from Ipanema. And both of those individuals, the girl from Ipanema, whom we think of as a youthful person, and Pele are now in their 70s. And we see them as much younger individuals, and they've grown older. What Alexander Kalachi, who worked for the World Health Organization and lived in Geneva, observed was that people were moving more frequently to cities, and that concentration of people who were growing older in cities should be addressed by changing cities. And what he observed in Ipanema that really caught his attention was that it had been a very young community. The girl from Ipanema and Pele and Alexander Kalachi saw it when they were in their childhood years and then grew up there. And what he observed was that the town is made up of high rises along the beach. And the high rises have doormen. And the doormen have become increasingly important in the lives of the people who live in the buildings, who then have become more dependent on what other people can do to be helpful. And the doormen have become the helping agents within the city. And because of that, it became important to him to make sure it was understood that the doorman's role had become much more than what it used to be. He also observed that people were on buses, the major form of transportation in Ipanema, and that the bus system worked as follows. It was very important to Ipanema to keep the buses on time so that when you went to the stop, the bus was there when you expected it to be there. And as a consequence, people who were older, who took extra time to get on the bus, were not getting on the bus because the drivers would pull away because they realized that that person was going to take too long and they'd be late to the next stop. So I think it's those two observations were important to him because they needed to make changes about Ipanema in terms of how the thought processes happened. The doormen ended up being paid more and trained to be involved and paid by the city of Ipanema to be supportive of the individual so that they could I've changed my words here. I don't say age in place anymore. I say living in place. So it's important to make it possible for individuals to stay there. They also changed the bus system to make it more important to have more riders than to have the buses on time. Now that would just tick off people in DC tremendously, because everybody wants the bus there when the bus is supposed to come, but that's got to happen if we're going to allow enough time. Either that or we have to space out our time that we allow people to get on the bus, and the bus drivers have to be mindful of this kind of thing. I think that's what set him off on, we've got to do this age-friendly initiative. And it's helpful, I think, to have some feel for the background of this. In DC, the faith-based community got excited about the fact that there was something going on from the World Health Organization that would be involved in transforming the city to face what we all know, we've known a long time, that our population was going to change. It's still, to a certain extent, largely ignored what we do with regard to what's got to be different about this, and how we've been helped in this country was the Americans with Disability Act, which came out of the Olmstead decision, which is a Supreme Court decision that said basically that people who were in a facility, a nursing home, needed to have an opportunity to leave the nursing home if the cost of care, this is now we're talking about public dollars being spent to support the person, if the cost of care was no more than the nursing home would cost to have them at home, they should be allowed to go home. That Olmstead decision really, really made a difference, along with the Americans with Disabilities Act, to make it possible for people of all ages to see the changes that we have begun to see that are really making a difference for all people. And I would emphasize, whenever we're talking about changes that happen for the disability community, we're making changes that help everyone. I'll just use curb cuts as the easy example for you, because curb cuts are used by people who are involved with unloading loads, who use the curb cuts to take their loads up the curb cut. People with strollers can use them. There are lots of reasons why curb cuts are much more valuable than we thought. What we were doing was to help people with disabilities in wheelchairs and other helpful devices. So it was adopted in DC because of the faith-based community lobbying. And I will just say to you, age-friendly activity has to be a political will that causes it, because the mayor has to sign a statement and the council has to agree to it to make the World Health Organization pay attention that there is another jurisdiction that's interested. When we began, there were 4 in the United States. This is in 2013. There are now over 400 in the United States age-friendly jurisdictions. The states of Maine, Connecticut, New York, Florida, Colorado, California have all become age-friendly states. So this is just taken off as a means by which to structure changes, all of them with the intent of making life easier for people as they grow older. So if I go to, so what you're seeing here is a history slide, what's happened in terms of when things were approved. And I just want to underscore that this is a political process. This is something that requires action by the government. Now, we in DC have our age-friendly activities going on with the leadership of the government. Across the country, there are different models. In Florida, where age-friendly is a state function, it started in the nonprofit sector. And often there is a nonprofit leadership to this or a university leadership rather than through the government. The problem then is that advocacy has got to be the way in which changes are made. It's easier if the leadership is in the government, and that requires, of course, spending money to pay me, not to mention other things that have to be done. So it's a different model. But anyhow, we've got, I think, the best model to have it in the government. The best secondary piece to that, and we're building it. Those of you who are involved with George Washington University can clap. I'm working with Wendy Wagner. We're going to have a university connection that's going to make George Washington University very much our research partner so that we can use something other than government measures to see our progress, which I think is really important. But anyhow, we're in at this point, at a point where we're going to do a summer study in the summer, this summer, to structure how we're going to evaluate and report on the results of the plan that was set forward that will end. We will finish all of this by December 2023. And Melinda, you did that report for the Department of Aging and Community Living. They're going to be doing a new state plan, and they're asking for an extra year. That plan was supposed to be revised this year. They're going to ask for another year, and we're going to be coordinating our activities to develop the next plan. I don't know when the RFP will go out, but I just would say that your work is going to be revised, and we're going to collaborate on the listening that's necessary to update our plans, because we will have a 24 to 28 age-friendly plan that hopefully, and I don't think there's probably going to be much of a challenge, the mayor will sign off on in the council.
That's really interesting, Gail, because I've actually seen a copy of the draft dementia plan, brain health and dementia plan. So I'll be curious to see how you guys coordinate with those, between those two.
We really think there has to be more collaboration.
Oh, I completely agree that the process of making the strategic plan around dementia, I think it'll be really good to kind of bring in you and a lot of the people that you have connections with to coordinate the two plans. I think it's necessary.
And I will tell you why it's necessary. All that you said with regard to what brain health means lend to the fact that there's a continuum of brain health, right? I mean, you can or a broad spectrum is what I'm trying to say. And we can't just label people who have brain health problems because of the fact that there's a blur along. We all have issues in one way or another that need to be worked on. Is that fair, Melinda? She's put herself.
I think so. Yeah, I'd have to think about it a little more.
Would you pipe up when you have that thought through a little bit? I just want to show you that we've got, this is a summary slide, and it's just useful for you to see what we're trying to accomplish. And what I'm going to do as I go through this is just lay upon you how I think this is connected to brain health. So if you look at the built environment, here are strategies within a plan that has 96 strategies. So it's not as if we're talking about the entirety of the age-friendly plan. But if you look at the built environment, this is the area where we have some impact over accessibility. We have, in terms of transportation, that's in the built environment, as well as housing. And if you look at the first one, which is a housing strategy, we really, really want home sharing. Can you see how people who are in need of more income, who have spare bedrooms, and we've got a scat of spare bedrooms in DC, could benefit from having someone live with them by making money from that asset. We want home sharing to happen. And I will tell you that that's gotten nowhere. Accessory dwelling units, we have $1.6 million in the DC budget this year to push accessory dwelling units. From a housing perspective, that means increase the density of the city. But it also, again, with brain health, if an individual has an issue or lives with someone who has an issue, it's nice to be able to create a separate unit. And we make it very difficult in DC, have in the past made it very difficult to build an additional unit on your property or within your structure. I think the easy example for that is if you wanted to use your basement as a housing unit, you're going to find it would be much easier now, because it used to be that 8-foot ceilings were absolutely essential, and now we've relaxed that. You can have less height and still have a residential unit in your basement. We're making progress on affordable assisted living. I would say the reason for that relates to age friendly. The issue for us is the fact that there was not enough reimbursement to encourage any kind of development. Now we have in Ward 7 and 8, 2 buildings that are open, Livingston Place and Kensington Place. We have one also on Georgia Avenue in the Walter Reed campus. Vision Zero is a national problem. This is our initiative to prevent people from being hurt through crashes. I have learned never to say accident again in my life. And the reason for that is because every accident has a cause, and there's something that someone didn't do that caused that accident. So think crash. But what we're talking about here is hurting pedestrians and cyclists with vehicles. And our major problem, as you might guess, is speed. And you're going to see that there are many, many more cameras on the road. You have seen, I'm sure, as you walk around DC, many of the barriers that we've put up between the bicyclists and the road. And we've got now a series of ways in which we make people take a much sharper right turn instead of moving on the hypotenuse. You have to go out into the intersection and make a sharp right to make the turn, because that means there's less surface area in the walking lane to hurt people. Does that make sense? Do you understand what I just said? And it does seem to be working, but our major problem is speed with people who are just moving too quickly, and the cameras, I think, are going to help us with that, although we'll see. It hasn't been proven yet. We've had more deaths this year than we did last year of pedestrians on the roads. We have made progress with dedicated bike lanes and accessible buildings. Drop-off zones have been added. We're making progress in that particular strategy. We have a problem with getting workers who are 50 and over into roles. It's thank you for what we are in now, which is a much more full employment time than when we started this plan in 2017. But we have a huge problem with long-term care workers, and that resulted from COVID. It's a very serious problem. It goes from geriatric physicians down to the entry level of workers. We just don't have enough people interested in working in long-term care. We're doing a lot of strategies to try to encourage that. The most recent position that was taken that helped us was that added to the fiscal year 2023 budget is money to encourage career development for people who are coming into the long-term care field. We have in DC, we're very proud of it, paid leave for caregivers. We'd like this nationally to happen, but it has happened already in DC. This functions like a program in which, if you know the workers' comp model, compensation model, each employer with 25 or more pays into a fund, and then people who have new family members coming into their lives, whether they are young children or babies or older adults who need more assistance, one can leave the workforce. What we've got as a problem that's left here is that there's a stigma associated with leaving the workforce to get involved in caring for somebody else. Becoming pregnant, it's a lot easier to leave the workforce now for paternal leave as well as for the moms who are leaving the workforce. We need to have that very same attitude about people who have to leave the workforce to care for people who are older. We want to report on how much volunteering is going on in the District of Columbia to show how much of a contribution volunteers are making. We're making no progress on that. If we go to tech connectivity, I'm very proud of the fact that we've got, thanks to the federal government for helping us, but much more connectivity, much into the areas of the city where connectivity was a real serious problem. We're giving away devices right and left. These are computers, iPhones, tablets, and then realizing that those pieces of equipment grow old and need to be replaced. And then the training, which is the big deal. What Loretta just did, I am hoping all and every one of us take the time to train one another when we have a problem with tech. Tech moves all the time, and we always need help, and we need to help one another to be as techie as possible. We cannot let people drop off and do it for them. Doing for is not the answer. We've got to train people to do this. The state of volunteerism is a repeat on the one above. It's clear that in my mind, that's a serious problem. So just know that this slide is not right. We did get the 2020 census results, and we're beginning to see the results of those data in terms of having an impact on the city. If, for example, I would just tell you, we have Ward 6 in DC that includes Capitol Hill, now includes parts of what used to be in Ward 8. And that's a change that occurred as a result of the count within the census. We are this issue of students who are 50 and over coming into colleges. Be proud. George Washington University is way ahead on this. Reducing the size of the freshman class, that's the right thing to do. We're not going to have as many students coming into the schools because the population isn't there, and there's going to be a lot of competition among the undergraduate programs to recruit students into the freshman years because 18 to 24 population is dropping. What is there and is growing, of course, is people who are 50 and over who need certifications, which George Washington University has been good at this, as well as degrees as they mature. We need to get back and refresh our skills, and that's the whole point of that particular domain. George Washington University is a standout. I just have to tell you, there are other universities in the city that are not as with it. I'm going on to the last pillar, lifelong health and security. We have a PACE program now. PACE is Program for All-Inclusive Care for the Elderly. People who are nursing home eligible do not want to be placed in nursing homes, period. End of story. There is nobody who wants to live in a nursing home. PACE is a program that exists for people who are nursing home eligible to stay in their home, surrounded by services. That the term is holistic. So there's a social worker and a willingness on the part of the PACE program to pay for accommodations to make it possible for the person to get out of the home with a stair riser, bars in the bathroom, all the stuff that you might anticipate that needs to be modified in order for people to stay where they are. This is a capitated program. Most of you know what this is, but anyhow, capitated means that Medicare provides the program with the average rate of reimbursement for fee-for-service in the particular jurisdiction that you're in. That's what the PACE gets, is that amount of money to cover the expenses for their per person for the individuals who are in their program. That program is starting in Ward 7. I am hoping that we see the sense of having it exist across the city. For those who are in the Medicaid program, we have a program called Services My Way that is stunning and doing a very good job with people who are choosing their own workers. Could be their adult children, could be someone else they like that they want working with them. And they, along with a manager who helps that individual arrange for the services. This is people who are nursing home eligible to stay in their homes and receive services there, with the services organized by people they care about, not people who are certified nurse assistants or home health workers. This is people they want who happen to be in their lives. The problem with that program is that we are finding that people need to hire home health aides, certified home health aides, for when the family members don't want to work. That would be if the person needs help at night. Family members don't like being awakened to take people to the bathroom, would prefer to have a service worker there. We have a shortage of home health aid work. And as a result, Services My Way is struggling particularly on the weekends, on the night shifts. We are addressing behavioral health, and wow, COVID made it possible for us to realize that telemedicine really needed to develop, and we're using, there's evidence now that counseling online with the kind of program in which we're talking to one another is working for people. So that's been an improvement over where we have been with our behavioral health in the past. I'm going to emergency preparedness and resilience, and just note to you that we are making progress. I would say the major progression here is because of lawsuits that occur as a result of things that have happened in other cities, where the advocates realize that they can prove harm. There's potential harm if a person were in a building that didn't have the kind of access that it needs to have. That causes the city to make changes that it would, and to face the public, the building owners, to make changes that they have to make in order to make the buildings accessible. That, as you know, inures to the value of everybody. So we do have now a retirement savings program for DC government residents that echoes the federal program, that when you become hired by the DC government, immediately 5% of your wages are put into a fund for savings for retirement. It's such a bureaucratic nightmare in the federal government and in DC government to get the money into your week or your monthly or your bi-monthly paycheck, that people just leave the money there. So over 90% have left their savings there. Before, the participation in the retirement savings program was as low as 10%. People just did not put money away for retirement. And that's because they thought that they had enough or could save later. Now, I'm stopping because I've given you a picture of what Age Friendly is doing. And I'm going to go back and comment to you that, to me, there's an overlay in every one of these strategies having to do with brain health. I'm going to rely upon you to help me out. What do you see here that fits with your definition of brain health.
So I'm a built environment person, and to me, the most relevant to brain health is the home sharing. Imagine, an older person sharing, or anyone, but especially an older person being able to share their home with a responsible, younger, say, student who needs a place to live. And just the interchange, the daily interchange, and what that means for the brain health of both those parties. Also, with the built environment, many people, the biggest barrier to them being physically active is it's not safe, or the areas, the sidewalk connectivity, they can't go out to walk for walks. Playgrounds are built in parks a certain way. So it's all relevant, Gail.
I know, and I just want to,
anything that fosters connectedness between people.
yeah, that's right. Let me just take you, this is the outdoor buildings and spaces leadership. You're looking at Anna Van Balen and Tama Duffy Day. Tama Duffy Day runs Gensler, is an organization that's very focused on neighborhoods and environment internationally, to make it more accessible and engaging for people to live in a particular place. Anna Van Balen works for the Department of Planning and Economic Development. But the one I wanted to point to you that's another strong strategy for purposes of community engagement with brain health are murals and other wayfinding devices across the city, because that kind of thing helps people to get where they're going without having to use any device, or because they are familiar with where that is. I'm gonna start calling on you just to see what's happening in your heads if you don't speak up. So I'll stop a moment and just let you redigest what I was showing you with that first slide, or just go quickly onward. I'm afraid that I've organized this in a way that's not as easy to. Could someone comment on transportation? I will if you don't, but I really would love to hear you talk about transportation and brain health.
Oh my God. Sorry, I had to go get something to eat. If you can't get somewhere, you're isolated.
Right.
And isolation and brain health don't get along very well. So transportation is vital. You have to connect, whether it's by sidewalk, or you have access to public transportation, or you're still able to operate a car. That's
right.
And with people.
And it's really, I mean, we in DC have some real issues with transportation. As we come out of this COVID experience, we're coming back into using scooters. And this, I know it's going to be an issue in the next plan. Are any of you scooter riders? I am, and I will speak if no one else does. Does anybody use scooters?
Yeah.
All right.
Oh,
go ahead, please.
Yeah, I was just gonna say, going along the transportation and also the technology aspect, like so much of the transportation in DC right now is technologically driven. So like scooters, you need an app to unlock it. Capital bike shares, you need some form of app to unlock it, or you need some form of technology to add money to a card or your phone. Same with like buses and trains, you need to check up wait times for how long they're going to be. So I think a lot of that is like communication and continuing to educate aging populations.
I couldn't agree with you more. I think that the tech piece of this is the one that I really wanted you to comment on. We've got an equity issue here. There's better transportation in the more wealthy parts of the city. But the reason I was bringing up scooters is because I wanted to point out to you that our older population are afraid of scooters coming up behind them and scaring them. And it's going to end up in the 24 to 28 plan to get people who use scooters off the sidewalks and into the bike lanes, which is not what feels comfortable for those who are involved in scooter use. But we also have a number of bikes that are going to be positioned, already are, but they're not well publicized, for people with disabilities to use. So if you have challenges with parts of your body that don't work as well as others, blind, there are going to be bikes for two that enable people to ride with somebody else. So these are going to be rental bikes that just are available that you can use. But again, it's the technology that's the issue that I'm particularly glad that you surfaced.
Gail,
yeah.
we have 1 minute left.
All right, we're going to just see one.
Your most salient.
I'm pushing it right here. I'm just going to show you what I think is as critical here in terms of housing. The equity plan is going to move us from where we are now with affordable housing. And I'm particularly concerned about you're seeing the dot in the upper left corner and how tiny it is and how much more housing we're going to want to have in the Northwest. I'm sorry, I lost track of time. It's pretty darn important to us to get there. If I run down these slides quickly, just letting the words slip over you, you're going to see that we cover a lot of territory that is going to have implications for brain health. I'm going to stop a second on abuse, neglect, and undue influence, because we have got to pay attention to that with regard to brain health in order to avoid having people take advantage of one another. And it's usually a family member, unfortunately, that is taking advantage of somebody else. And with that, I'll scoot through this to a term that, again, I'm going to get rid of. That caregiving term is going to become care partnering, to make sure that we learn from what is an ageist hierarchical term to one that's much more egalitarian in terms of thinking. I really appreciate having this conversation. I've enjoyed talking with you and hearing your comments.
Gail, thank you. Thank you so much for your contributions, not just to this seminar, but to so many different facets of GW, the classes that you come to speak in, the partnerships that you formed with us. It's just incredible. And your reach is certainly felt throughout the university. And as always, when you need things, feel free to ask. We have students who more and more were fostering an aging, interest in aging. That wasn't really true when I first got to GW, but Samira is on board, Melinda's on board. Gradually, as the faculty, at least in the School of Public Health, and then in the medical school like Keith, I think we've really have now a groundswell of people truly interested in age-friendly and successful aging, and certainly your work. So thank you very much.
One quick advertisement. Keith and I were talking about intergenerational walks for health. This affects brain health. And what this initiative is about, which we've been doing throughout the spring, was walking with youth and older adults together in Adams Morgan. And the Oyster Adams students speak in Spanish because it's a bilingual school with people who primarily speak in Spanish. So Keith is going to be working with us on adding the physical therapeutic component to this, because there is more to be done. There's much more rich stuff to be done with this.
Yeah, we had one student already doing that who thought she had a blast.
I'm so glad. That's great.
All right, everyone, thank you for your support of our seminar series, and see you in the fall.